Well, good morning, and we think we should get started. It's 9:30. We've got a very full day. My name's Professor Wardlaw, and this is my colleague.
I'm Edwin van Beek, and welcome all to your opening launch of the Edinburgh imaging facilities and what we can do. There's a few usual housekeeping things. So there's no fire alarm due, so if it goes off, we'll have to leave. The nearest toilet is outside the auditorium through the door on your right, just beyond the lift. Please tweet if you want and use the hashtag EIOS17. This event is recorded, so if you have any questions, can you please wait till the microphone is there before you start screaming across the audience. We have CPD credits for this, so you have to complete the form. So if you complete the form, if you want CPD, you have to complete the form and hand it back in. At the end, then you'll get a certificate that will count towards your CPD. Tea, coffee and lunch is going to be served upstairs in the Mary Kane Ross room. That's 2 floors up from here. There's a lift available for those who can't walk 2 flights. And at the end of the day, there'll be a drinks reception also in the same place, so please feel free to join us for that. Back to Joanna.
Yes, well, thank you very much. Thank you all for coming. The purpose of today is to welcome you to the superb new facilities that are available in Edinburgh as part of Edinburgh Imaging. So this is a scientific celebration of some recent acquisitions. In the last year, we installed a magnetic resonance positron emission tomography scanner in the basement of this building, which combines the strengths of those 2 amazing technologies. And also in our hospital just across the way, we installed a state-of-the-art brain-focused research imaging MR scanner. And this adds to amazing facilities which are already available and make it possible to do all sorts of extremely exciting research now using medical imaging technologies in Edinburgh. This represents a culmination of a really massive effort on the part of a very large number of people, in particular the university for having the vision to advance this and support the efforts, many funders who've contributed to the ability to purchase the scanners, in particular the Medical Research Council and the Wellcome Trust, and many individuals who've given a lot of their time to make it happen. We were fortunate to have Princess Anne come and open our facilities back in February, and so today is a scientific celebration of the capabilities and the interests. We have several themes. They reflect the interests locally, including metabolic imaging, cardiovascular imaging, and neurological imaging. We're extremely grateful to our 3 eminent international speakers who've come to share their knowledge with us today, and thank you for giving up your time and coming to talk. And also grateful to the chairs and the other speakers from Edinburgh who will tell you about what they're doing, and also it's an opportunity to hear about the facilities and how you access the facilities and other materials that are available. In particular, I'd like to thank 2 individuals who really made today possible, and that is Moira Henderson and Jane Barr, without whom today would not have happened. So without more ado, we'll hand over to Scott Semple, who's going to chair the first session. And please enjoy the day. Please ask questions and take the opportunity to meet people and find out how you can do some really fabulous imaging research.
Thank you very much. I've just seen Professor Chris Boesch's CV up there. I'm not sure I can entirely do it justice. We're very grateful for Chris to come along today. He's joining us from the University of Bern in Switzerland. Chris has been heavily involved in some of the biggest international societies for magnetic resonance, particularly the International Society for Magnetic Resonance in Medicine and the European Society of Magnetic Resonance in Medicine and Biology. He's been president of both of these societies and is now an honorary fellow of ESMRMB. He's had countless Swiss National Science Foundation awards and published extensively over the years, particularly in the field of nuclear magnetic resonance spectroscopy. He's going to be talking today about metabolic imaging. Chris, thanks.
Thank you very much for the introduction and in particular the invitation to this wonderful event and to your wonderful Scotland, which I love very much, and I'm, whenever possible I'm visiting it. I was smiling about my CV because the European Society, ESMRMB, has been mentioned, but not the ISMRM. I take it a little bit as a sign, a European sign of Scotland. I will speak about metabolic imaging using MRI, and I have to restrict and to focus on energy metabolism because everything else would take too much time, and within that I will mainly focus on lipid metabolism. The content of the lecture will be mainly that MR can observe metabolism with different mechanisms. MR spectroscopy in particular represents a direct view of the metabolites. And chemical shift as a tool and as a basis for spectroscopy can identify molecules and metabolites on different mechanisms. And then I will focus on MR and lipid metabolism. When you are looking at the classical spectrum, you have two aspects. One is the chemical identity, which is on the x-axis. You can see here lactate with two groups, the CH group and the CH3 group, where you have an identification of your metabolites. On the other hand, you have a concentration, which can be measured by the signal intensity as soon as you are doing proper acquisition. However, that's not the only way how chemical shift can be used to identify metabolites. One of the very common ways is spectral identification in the images with a fat-water image or a Dixon or extended Dixon techniques, but also hyperpolarized spectroscopy, most recent and very fascinating method. There we have either the spectra or we have the images of single metabolites for a very short time, but with an enormous sensitivity. At least for spectroscopy, it's an enormous sensitivity. Or CEST, for example, where you are irradiating on the different places in the spectrum and the chemical shift, and are looking at the water signal, which then amplifies your observation very much. So it's much more sensitive than classical spectroscopy. On the other hand, the specificity is a little bit lost because we are just irradiating NH independent of the different molecules, but also an extremely exciting method, in particular amide proton tomography, which is showing here, which is shown on the right-hand side for the detection of malignant tumors. Let's go to a very poor physicist's view of biochemistry. We have an energy metabolism of lipids and mainly carbohydrates, and we are going down the lipolysis and glycolysis to acetyl-CoA and the TCA cycle, where we gain all the ATP and so on, which we need for power, for neural activity, and so on and so on and so on. And I will just show you on this very simplified graph on how many places MR can really have a view on. For example, for carbohydrates, we can use carbon-13 for glycogen, phosphorus for the high-energy phosphates, proton MRS for glucose, and so on. Then we have the possibility with either hypolarized carbon-13 or labeled acetate to see the glutamate, which is labeled. So carbon-13 can help us a lot to see into the TCA cycle, for example, TCA cycle flux and so on. On the other hand, acetyl-CoA, as you will see, and acetyl-carnitine are related, and we can look at it with proton spectroscopy. Lipids can be in adipose tissue, and we have the opportunity to look at it with imaging, with carbon-13, with proton MRS. The ectopic lipids, IMCL, IHCL, so intramyocellular lipids, intrahepatic lipids, intracardial lipids, intrapancreatic lipids, we can look at with proton MRS and also MRI. Membranes can be characterized by phosphorus spectroscopy, and choline can be looked at by proton MRS. So you see a full view of all the different pathways is possible. I will not speak about carbohydrates. That's a lecture on its own. So let's concentrate on lipids and energy metabolism of lipids. Lipid metabolism can be both. It can be, or it is essential for human well-being. We need it. On the other hand, it is basis of major diseases. And MR can elucidate lipid metabolism in vivo, not so much in the details of the biochemical pathways. There we need more sensitivity, as you will see, but rather we have keyhole views based on animal studies, on cellular studies, on radiotracer studies. We know that we have a certain view where we can then use MR MR spectroscopy in the complex human system to look at specific points. The functions of the lipids are energy storage, thermal isolation, cell membranes, myelination, and precursors for hormones and biosalts and so on. I will mainly concentrate on energy storage and cell membranes. When we are looking at Michelangelo's David, ugly people say before and after a couple of weeks in the States, then we have here both aspects. Lipids are essential for maintaining physical power. When I have been in the Highlands, I have seen so many bikers, and they wouldn't work when they wouldn't have lipids available. And on the other hand, lipids can introduce insulin resistance and subsequently stroke and cardiovascular insults, the two big killers of human beings. And as a central message of my lecture, I want to tell you that the athlete's paradox, and that means that well-trained athletes and insulin-resistant patients both have high, large intramuscular lipid stores. And that shows you a little bit the two aspects of lipids, which are for the well-being as well as that they can introduce a disease. When we are going down the lipolysis and acetyl-CoA, we have on the left-hand side two aspects, inflammation and lipotoxicity. Both are not so much accessible to MR. Here we need more sensitive methods, and they are also culprits of the insulin resistance. So that is not discussed currently, but just as a reminder, our limitations of MR, in particular MRS, the spatial resolution can be much better. You can have single photon techniques in cellular systems and so on. Then we are working with millimolar concentrations, while the text detection limits for other methods like radiotracers and so on are micromolar, nanomolar, and even down. And our chemical identification is only sparse. We only see a few metabolites, while, for example, high-resolution NMR or mass spectrometry has much more resolution in that respect. Nonetheless, we have some advantages, and that is that we can look at the different compartments specifically. We have adipose tissue, which we can see. We have ectopic lipids, as I have seen, as I told before, and I will continue with that. And the strength of MRI and MRS is that we know the exact location of our observation, while, for example, mass spectrometry of breathing air, which is extremely sensitive and a wonderful method, but it's not so clear which organ is really contributing to the metabolites. While we can look at adipose tissue, we can look at skeletal muscle, the liver specifically, the cardiovascular system, and the pancreas. And that is the strength of MR. So let's start with adipose tissue. The group in Tübingen has shown that people with insulin resistance have more visceral fat than healthy people, insulin-sensitive people. This has, it's a large study, an important study. It has been challenged to a certain extent how important the visceral fat is, but nonetheless, it's a very important contribution to the understanding of insulin resistance. The lipid composition can be studied by MR spectroscopy. Here in a model solution, NMR solution, there you can see that all the CH2, CH3, and CH groups in a lipid in a fatty acid chain can be distinguished. We are not able to see all the resonances in vivo, but nonetheless we have access, for example, to the methyl groups and the methylene groups. And to a certain extent, it is possible to combine the spatial and the spectral information here in a publication from the UCLA group, where they are combining the spatial information by multivoxel MR spectroscopy, chemical shift imaging, and also the chemical information by the spectral resolution. Carbon-13 can be used to look at larger volumes of adipose tissue, and in this study from the Pasadena group, they were comparing adult controls, pediatric controls, and then people who had mainly seafood, a seafood oil diet with a lot of polyunsaturated fatty acids, and in contrast, people with a Lawrence oil diet, which is mainly constituted of monounsaturated fatty acids. And one can see that our body is really reacting on the diets and changing the contribution of the two different types of fatty acids. Brown adipose tissue would be, or actually is, an extremely important observation. However, here we are far behind radiotracer studies. There are certain ideas about hyperpolarized studies of brown fat adipose tissue, but nonetheless, when you look at the images, we can see fat, but the distinction between adipose tissue, white adipose tissue, and brown adipose tissue is very complicated, while a PET radiotracer can show it quite nicely. Let's go to skeletal muscle. When you are looking at an ordinary spectrum, then you can see from the left that we have deoxymyoglobin, carnosine, creatine, TMA, and so on. But let's concentrate on the two lipid types, the IMCL and the EMCL, which are chemically more or less the same, but they are separated by susceptibility effects. The subcutaneous fat and muscle or fascia consist of extramyocellular lipids. These are lipids between the cells and bulk fat, while the intramyocellular lipids, the IMCL, are very small droplets, very close to the mitochondria and within the muscular tissue. Already this adjacent, the neighborhood of mitochondria and lipids droplets show how important they are and how dynamic they are actually. The correlation or the relation between mitochondria, where the energy is then produced out of the lipids, is actually very important, and you will see more in the future. However, the techniques, just a technical comment, when we are going and acquiring single voxel spectroscopy but hit a little bit of subcutaneous fat, the signal of EMCL, which is much more abundant and more concentrated, is so strong that we don't see IMCL anymore. Even if we hit only a muscle or fascia, we have the problem that the EMCL signal is much larger. So we really have to be very careful positioning our voxel that we can study the IMCL, the dynamic part of the lipids, which are, as you see, also related to insulin resistance. We can look at EMCL, the distribution of EMCL, if we are mainly interested in the extramyocellular lipids by specific spectral, spatial selective pulses or Dixon methods and so on. But on the other hand, we are also interested in IMCL, and that is not possible by these methods. The lipid droplet size, for example, is an extremely important parameter. In a study from Goodpasser and Kelly, they were looking at the change of the lipid droplet size by biopsy studies, by the way, and correlated it to insulin sensitivity, and have seen that the droplet size obviously is related to the insulin sensitivity, and we can imagine that the lipid droplet, when you have smaller droplets, the surface to volume ratio is much better than if you have larger droplets. So that could be one of the mechanisms that the mitochondria and the protein which are working on the lipid burning, that they have less problems if the lipid droplets are smaller. We wanted to look at that in humans. And actually, when you know with diffusion spectroscopy, diffusion-weighted spectroscopy, you can distinguish between free diffusion or restricted and hindered diffusion. And if the droplets are small enough, we can see that either a restriction or a hindrance. Actually, what we have seen, when we are looking at EMCL, the extramyocellular lipids, we found actually a diffusion behavior from the left to the right. We have increasing diffusion weighting with increasing gradients. And we have what we expect, a very low ADC because lipids are not water, so it's a very slow effect. On the other hand, IMCL was even worse. We had almost no effect of our diffusion gradients because the restriction or the hindrance and the limitation via the droplets was obviously so strong. To measure this, the droplet size and the effect of diet, of physical activity, and of pathology on the droplet size would require more gradients, stronger gradients, and actually we were very happy that we had announced that we get a Prisma about 3 years ago, but because of the building problems which we had in Bern, we were waiting until last year that we got the Prisma. Meanwhile, the group in Hong Kong, they had a very strong gradient system in a 7 Tesla animal system. They were working with animals, and they have seen that with 2 different mixing times in a steam sequence, which can elongate the diffusion time, they didn't see any, as expected, no IMCL content difference. However, the IMCL ADC was changing, and that was a sign that they already could measure the droplet size, at least in an animal system. So that is one of the hopes, that we can study droplet size and this important parameter in vivo, in humans, depending on diet, physical activity, and so on. IMCL, as I said, is a very dynamic metabolite. When we are exercising, we can reduce it within hours, and within hours and days we can replenish it by an appropriate diet. For example, this is a very illustrative example where we had one person doing 2 marathons, and we had a drop of, before and after marathon, we had a drop of 3 muscle IMCL, vastus medialis, intermedius, and tibialis anterior. And then with a low lipid diet, the replenishment was very slow. On the other hand, with a high lipid diet, one can see that it has even an overshoot, and we have a replenishment which is very strong and fast. While we were looking at IMCL mainly in terms of power requirements and energy supplementation and so on, 3 other groups were then in the 90s, late 90s, publishing a negative correlation between IMCL and insulin sensitivity. And we can see here, they have seen that obese diabetes patients had higher IMCL levels. Higher IMCL levels were related to lower insulin sensitivity, the next group. And then higher IMCL levels in insulin-resistant patients were observed by the Tübingen group. And we were a little bit puzzled because what we have seen between endurance runners and sedentary subjects, when we are looking at the insulin sensitivity and the resting IMCL levels, we had a positive correlation. So completely different. We had high IMCL levels in insulin-sensitive endurance runners. And the group in Tübingen again, they were studying then the 3 groups, sedentary, athletes, and patients. And the plot is a little bit complicated. Let's look at it in more detail. We have here low and high IMCL levels on this axis. On this axis we have athletics against sedentary measured via the VO2 max. And here it's indicated insulin sensitivity or resistance. When we are looking at on the right-hand side, when we are looking at couch potatoes or sedentary people, then low IMCL means it's related to high insulin sensitivity, while High IMCL is shown in insulin-resistant people. However, if we go to athletes, higher VO2 max, we see that athletes have high IMCL and are insulin resistant, and so those who are less trained have lower IMCL levels and also are more, not resistant, but less sensitive. So we have this U-shaped behavior from insulin resistant versus sedentary versus athletes. And when we are looking at the insulin resistant people, obviously IMCL can be stored, but it cannot be used anymore. In sedentary people, we have not so much storage, but it's also not too much used. And in athletes, we have the full dynamic range. Athletes can store IMCL and can use them in the next power, in the next endurance sports activity. And obviously, IMCL is not so much a cause of insulin resistance, but much more a consequence of insulin resistance. Let's now go to the liver. We can use different methods. Imaging has been proposed as well as spectroscopy. Spectroscopy is today recognized as the gold standard, mainly because at very low concentrations of lipids of liver fat, imaging is generally overestimating the liver fat, mainly because of the magnitude character of an image, so you have no negative sign possibility. On the other hand, as soon as it goes to pathological levels, MRI has the advantage, is also reliable and has the advantage that you see the spatial distribution of your lipids. The combination of carbon-13 and protons in this group, in the study of the Yale group, what they have done is they had 2 carbohydrate-rich mixed meals in elderly and younger volunteers, healthy volunteers, and they were looking at the concentration of glycogen using carbon-13 in the upper graph, or in the lower graph, the proton spectroscopy of hepatic triglycerides, IHCL, in the 2 groups. And the open bars represent young subjects, while the closed bars represent elderly subjects. And we can see there is no difference in the glycogen concentration, but the lipids are increasing in elderly subjects, sorry, not patients, but subjects, who are usually more towards the metabolic syndrome. Even if they are not patients, they are less insulin sensitive than the younger. The cardiovascular system can be followed by spectroscopy. It's technically quite demanding. One has the problem of the moving organ, of the small septum, and so on. And the group in Amsterdam, in the Netherlands, has done extremely important and very nice work, and one can really look at the triglycerides, including also creatine and choline, in the septum of the heart. We were then combining that with a study during exercise of the heart, the liver, and muscle. So we were looking at IMCL in the skeletal muscle, IHCL in the liver, and we were looking at intracardiomyocyte lipids in the heart. And before and after exercise, we had a drop in the heart, a working organ, a working muscle. We had in skeletal muscle, we had a reduction, and interestingly in liver, we had an increase of IHCL after exercise. And it can be explained by the fact that while working, glucose and glycogen is used in the working muscle, but IMCL is also used in the working muscle, while the adipose tissue is releasing free fatty acids via bloodstream, and the liver is taking up the excess free fatty acid, so IHCL is going up during workload. So we can really see the different aspects and the different organs. The study, the Dallas Heart study, even if they didn't have any comparable quality of spectral quality as compared to the Netherlands, for example. The study is extremely important and contributes a lot. They have shown that myocardial triglyceride, as we say ICCL, is higher in diabetes patients or in ingested glucose tolerance and in obese as compared to lean. And what's important in particular here is that there is no correlation between hepatic triglyceride, IHCL, and ICCL, the myocardial triglyceride, and also not between serum and myocardial triglyceride. So obviously, it's necessary that we are looking at the heart. It's not reasonable that we just say, okay, triglycerides are high in the serum, so we can assume that in all the organs triglycerides are high. That's not the case. We really have to look at the different organs specifically, which is good news for MR spectroscopy and MRI. Pancreas. In the pancreas we have lipids. However, a study from the Düsseldorf group, Roden and co-workers, they have shown that there is no relationship between pancreatic adipose tissue infiltration and beta cell function. Here spectroscopy has the problem that the moving organ poses some problems, because as soon as the voxel is once or twice in the adipose tissue surrounding the pancreas, we have a strong lipid signal while the imaging techniques help us to distinguish the surrounding adipose tissue and the pancreas. So here I would even argue for MRI and Dixon techniques. Acetylcarnitine, we have seen during exercise and identified acetylcarnitine as at 2 ppm, the signal which shows up after exercise. And this acetylcarnitine has two functions. One, it's involved in the transport of fatty acids into mitochondria, but also it's an excess buffering of acetyl-CoA. And acetyl-CoA is an extremely important metabolite at the entrance to the TCA cycle, as you have seen before. And because we have this relation, it has been shown in the horse, but we can expect that it is in other animals and humans also the case. We have this relation between acetylcarnitine, which is observable, and acetyl-CoA, which is not observable by MR spectroscopy methods, but which is extremely important. And the group in Maastricht has shown very nicely that the relation between insulin sensitivity and acetylcarnitine concentration. The insulin sensitive people have a stronger signal of acetylcarnitine, and obviously we are here at the entrance to the TCA cycle with acetylcarnitine and the relation to acetyl-CoA, where we can begin to study the TCA cycle and what happens with the energy supply in insulin resistant or insulin sensitive subjects. When we are looking at the lipids and going down to the TCA cycle, as I said, we have the possibility with hyperpolarized carbon-13 or labeled acetate to look at the TCA cycle flux. Just one example from the Lausanne group. They were looking at the acetyl-CoA synthase via hyperpolarized acetate, and you see here that acetylcarnitine is showing up. One of the problems, but I think that will be solved soon, because say never in MR, because always someone is ingenious enough to find a way. The timing is actually a little bit a problem. In the Yale group, they were looking at glutamate when they were injecting acetate, labeled acetate, and that took minutes to hours that you have seen an effect, while hyperpolarization is gone after seconds. So we have this mismatch of the timing, but nonetheless there are attempts, and I'm sure that this problem can be solved. And with hyperpolarized CAM13, there would be a great tool to study the entrance and the TCA cycle itself. When we are looking at lipids, we also have to speak about membranes, which we can study by phosphorus spectroscopy. Here in a multi-center study, they were looking at the diffuse large B-cell lymphoma, and they were seeing that that they can predict the outcome of the first-line chemotherapy by just looking at the phosphomonoester pool, standardized by the NTP signal. But the phosphomonoester pool is the precursor for the membrane metabolism, and obviously helps us to see how strong the membrane metabolism is activated, and it's then related to this lymphoma and the possibility to influence the growth of the lymphoma. And also choline is used for looking at the malignancy of tumors. Choline is actually the head group of phosphatidylcholine, and this can be used also via the membrane metabolism. You see on the left-hand side the total choline signal, which is often used for measuring the malignancy of breast tumors, for example. The problem is a little bit the technical one, because these authors very often use, if total choline is visible, then it's a sign for malignancy. On the other hand, the visibility of this signal is strongly dependent on the signal to noise. If you have more noise, you don't see your choline. And so the standardization is in the moment missing. Some are suggesting absolute concentration measurements and so on, but it's quite difficult. On the other hand, there have been a meta study where they were looking at the standardized ROC curve and got quite some nice results of sensitivity and specificity for this kind of study. So this total choline still has some technical problems, but is often used and obviously quite helpful. So for the lipid metabolism, I have the following take-home messages. An efficient lipid metabolism is crucial for our well-being. It's not just bad, it's necessary to have endurance power. On the other hand, as soon as it's impaired, it's a source of major diseases which should be prevented and not looked at later on, but they should be prevented. And MRI and MRIs are well suited to study lipid metabolism non-invasively. I've mainly looked at body composition, IMCL, IHCL, lipid and cancerous tissue, which are where we have a lot of clinical studies at 1.5 and 3T, while the other points, brown adipose tissue, lipid composition, ICCL, acetylcarnitine and so on, are mainly methodological developments or in animal studies, but they are perhaps the acetylcarnitine and so on soon more used also in human studies. We have seen the limitation of MRI and MRS, the spatial resolution, which is a problem, the detection limits, chemical distinction, which is relatively poor if we compare other methods. So we see MR is particularly suited to study metabolism. I've mainly looked at energy metabolism, but also in other types of metabolism. As soon as we are looking at it repeatedly, and in healthy subjects, MR can contribute a lot. It has various modalities which can be used, mainly based on the chemical shift dispersion, as for example CEST and hyperpolarized. PET and SPECT are much more sensitive, and I'm usually very jealous if after a lecture of PET people, because this sensitivity we never can have with MR spectroscopy. On the other hand, the lipid metabolism and studies of insulin resistance are particularly beneficial, or the MR is particularly beneficial because it's non-ionizing. If you, for example, imagine studies on pediatric obesity, it's easier to have repeated measurements and before and after exercise, before a training scheme and so on in pediatric patients when you are using MR. And PET and SPECT, as I said, are wonderful methods and particularly sensitive, but here we have some advantages. Thank you for your attention.
Thank you very much for a fascinating talk, a really good overview of spectroscopy. We do have 5 minutes for questions. If you don't mind, I'd probably like to just start off myself. So I'm quite a fan of spectroscopy and its applications, and we get approached quite often, particularly by our colleagues in hepatology, for example. You know, they often get asked the question, what's the gold standard of hepatic fat fraction measurements? Mm-hmm. But they are often also interested in heterogeneity in a pathology. And so, particularly for things like multi-center trials, we use imaging and then MRS as a sub-study because it's technically challenging, or it's seen to be anyway, and particularly if you're looking at scanners from different vendors and different sites. And over the last 20 years, I've seen imaging come along leaps and bounds and a slower trajectory perhaps for spectroscopy. So what do you think needs to happen? Because I mean, it's clearly a fantastic tool, and it feels like that, you know, it's almost there. It's almost ready for clinical translations. What do you think needs to happen?
Yeah, spectroscopy has a little bit the image of always being promising since 1990 something. And I think one should forget a little bit that spectroscopy will be a clinical diagnostic tool in all patients. That means in single patients. What spectroscopy can do is contribute to textbook knowledge. That means we can understand mechanisms, as for example IMCL, TCA flux, and so on. So we can learn a lot of it. But it's not so much the all-day tool which is used in every single patient. I learned that during the years, perhaps because we had mainly prospective studies due to the structure of my group and so on. But I also have the impression that creating textbook knowledge sometimes can even be more helpful than to look at each patient. Because if we understand the diseases better, then we have better treatment, we have better and whatever. And so I'm usually a little bit stepping back when someone is asking, when are you clinically important? I think spectroscopy is clinically important, but more to learn about our body than to diagnose the single patient. I'm a little bit special in this case, to be honest. I think spectroscopy can have a value also in the clinical work, the daily routine. I know from our neuroradiology department that they very often run the spectroscopy and a spectrum in addition to the other modalities, and say that it is quite helpful. Yeah.
Everything's easier in the brain.
Yeah.
Okay, open for questions. Joanna?
Yes, thank you very much. That was extremely enlightening. You didn't mention much or anything about the brain, but obviously the brain has a major fat content, and myelin is a tissue of particular interest. I just wondered if any of these measures, or if you had any experience of applying intracellular versus extracellular measurements of, say, myelin in the brain in relation to things like white matter integrity and so forth, or if you knew of any other work going on in that area.
I don't think, and the reason is a little bit the physical background of intra versus extra. Within a voxel, you need a certain preferred direction of your lipids plates. And then you have this susceptibility effect. which is actually the case in muscle, where you have the fasciae are along, along the magnetic field when you have your leg. In the brain, I think the structure is so small in certain parts, or main parts, that you would have a mixture. You have seen the spectrum of the cardiac lipids. There you also don't see two lipid contributions, because the separation of intra and extramyocellular doesn't happen if you have a mixture of your fiber orientation. And the fiber orientation, perhaps in certain parts of the brain, but even then you would need an extremely small sample size, the voxel size that you could do. And so far, I haven't seen any work which has been done in that respect.
Follow up, it's just that in the brain we now have very advanced techniques for identifying key tracts, which might just give you enough of a well-orientated fiber bundle that might just have enough directional integrity in it to,
Yeah, completely.
So there are ways of sort of putting your voxel in a tract and just see if it would work on that basis. We're doing that with other methods like very detailed structural imaging, linking lesions to tracts and so on, and we're working at really small levels. So maybe it's worth a shot.
The problem is, you are completely right, but you are looking at water. Our problem is we are looking at the lipids, and the signal of the lipids is much, much, much smaller. That means we need much larger voxels. Our voxels are usually 2 centimeters or 1 centimeter times 1 centimeter times 1 centimeter, while a DTI voxel is much smaller. And even there you have the problem of crossings and so on. So if we would look at water, then we could see it, and then also diffusion, the DTI measurements of the brain are extremely promising and wonderful. But with a water signal, which is several orders of magnitude stronger than what we are looking at, you can have much smaller voxel. And then you can go down to at least some 10 to the, fibers, which are in the same direction. So that's our problem, that when we are looking at metabolites or lipids, that then we need voxels which are much larger than the typical fiber. That's also, by the way, one of the reasons that I'm a little bit critical about spectroscopy in the brain on tumors, because spectroscopy it has simply not the resolution, the spatial resolution. And there I think, CEST for me is also kind of a spectroscopy. There are these techniques where we are going via the much stronger water signal, and then we can have much smaller voxel and better spatial resolution. I think that's then the way to go. But you are completely correct. That would be interesting.
Thanks. Probably in the interest of time, we'll continue that. Any further conversations at the coffee break, so we'll move on to the next speaker. Thank you again, Chris. So continuing our theme of metabolic imaging, we've now got Dr. Roland Stimson, who's been doing a couple of projects with us, about to start another one in the Imaging Centre here in the building. Roland is based in the Centre for Cardiovascular Sciences upstairs. He's an honorary consultant endocrinologist and an MRC clinician scientist. Probably has, without a doubt, the best topic of the day, measuring hot fat in a cool man, which is pretty good. One of the most fun projects that we've done. Roland, thank you.
Is that better? Okay, good stuff. Okay, so I'm going to stay on the fat topic, but I'm going to move from the white to the brown fat. So, as mentioned already, the obesity prevalence is a big problem. Over a quarter of all adults in the UK are now classed as obese, and 2/3 are at least overweight. And it's associated with a large number of comorbidities such as hypertension, diabetes, cardiovascular disease, certain cancers, infertility. And it's estimated that obesity costs the NHS approximately £6 billion a year. And obesity can be broadly classed as a chronic imbalance of excess energy intake compared to energy expenditure. And there's been a lot of attempts of pharmacotherapy to try and treat obesity, and they've very much focused on this side, the calories inside of the equation. And some of them have been effective, some of the medications, but they have had substantial side effects, and they've been withdrawn. And there's only actually one agent licensed in the UK for obesity treatment at the moment. And the other side of the balance, the calories out, has kind of been largely ignored. And when we think about obesity, what we're talking about is excess white fat, this guy here, which is broadly defined into visceral and subcutaneous adipose tissue. But there is another depot, brown fat, which is incredibly important in rodents and is present in the interscapular depot there. And while white fat's primary role is to act as an energy store for release of fatty acids for nutrition, brown fat has a different role. It's there to maintain our body temperatures by generating heat in response to a cold environment. Okay? So, and it does this by this unique protein, UCP1 uncoupling protein 1, which is only present in brown fat. And what that does is it allows you to basically uncouple energy production from ATP synthesis, and then the energy can be released directly as heat. So in essence, it's an energy inefficiency protein. And we know that babies have brown fat in the interscapular depot. You can see there. But by around 1 to 2 years of age, that's basically been replaced by white fat. And it was thought that adults didn't have any brown fat whatsoever. However, PET-CT kind of changed that. And so this is a PET-CT scan using fluorodeoxyglucose, which is the most commonly used for diagnosing malignancies. And if you do an FDG PET-CT scan at 27 degrees here, you tend to see just uptake brain and heart or any other abnormal tissues. But if you just do a mild cold exposure, so 19 degrees, not that much, in some individuals you will see substantial FDG uptake in other tissues. Predominantly the supraclavicular depot is the most common, then perispinal, and you do see some in perirenal in certain individuals who have an awful lot of it. So some adult humans do have brown adipose tissue. And what got us very much interested in the fact is that if increasing BMI, increasing weight, the less brown fat you have, implicating potentially it as a causative mechanism. And we also know that brown fat, having brown fat is associated with improved glucose tolerance, and also it contributes to lipid clearance. So it seems to be a metabolically beneficial organ. But if you haven't got any, not all hope is lost. Because if you want to do some cruel studies on people and basically do PET-CT scans before and then do 2 hours of cold exposure every day for a couple of weeks, you can actually then lead to enhanced FDG uptake following repeated cold exposure. And we certainly see increased FDG uptake during seasonal variation higher in the cold. So it's a very plastic organ. So potentially people have precursors to brown fat that can then actually be differentiated and grow new ones. So there's a lot of pharmaceutical interest in activating this tissue as a novel strategy to treat metabolic disease. However, most of what we know about human brown fat is based on rodents. And what we're very interested in is looking to see whether there's differences between humans and rodents. So we know that glucocorticoids are one of the most powerful suppressors of brown fat activity in rodents. So we wanted to kind of see whether the same thing was true in humans. So this is kind of one of our typical studies here. We recruited lean, healthy individuals, randomized them to a placebo-controlled crossover study, giving them a glucocorticoid prednisolone or placebo with a washout phase. At the end of their glucocorticoids, which is just 1.5 days, we put them in a warm room, 24 degrees, for 2 hours. Then we put them in our cold room. We have a kind of climate-controlled cold room in the Crick facility. 16 degrees, 1 hour into cold exposure, we give them FDG, and then we do a PET-CT scan an hour later. We also infuse deuterated glucose to look at whole body glucose kinetics. And as you would expect with steroids, we saw a reduction of insulin sensitivity, so decreased glucose uptake on the prednisolone phase, so whole body insulin resistance being induced. However, in contrast to my hypothesis and what happens in rodents, we actually found increased FDG uptake by supraclavicular brown fat on the prednisolone phase, which we saw in most individuals, apart from this guy who cheekily told me he'd had a Big Mac meal that morning after we've discovered the results. And that's probably a confounding effect of why a lot of people work on rodents rather than humans. But increased FDG uptake by brown fat doesn't necessarily equate to increased heat production. So in parallel, we thought we'd try and look at another imaging technique. So got in contact with our friendly military hardware stockist who so does infrared camera. So we can have a look at supraclavicular temperature. And in the circles here, this is the areas of the skin overlying brown fat, and anterior chest there, an area not where brown fat you don't see. And we did the same study again, and we found the same thing, that actually prednisolone enhanced supraclavicular temperature during cold, but not during warm exposure. And also, interestingly, that it enhanced whole body energy expenditure only during cold rather than warm exposure. So the glucocorticoids are preferentially activating brown fat during cold. And so this is quite exciting evidence that human brown fat regulation is different than that in rodents. That's acute. What happens chronically? We know that prednisolone steroids actually cause people obesity. Now, we can't give people steroids for months on end. So what we've done is actually used the kind of PET-CT database that we have here, patients who've undergone PET-CT scanning. And so we've gone through records and actually found 130 people who'd been on glucocorticoid treatment for at least 2 weeks. And then we matched them with age, BMI, glucose, disease, sex matched individuals who'd had PET-CT scanning as part of their diagnostic investigations. And what we found was the exact opposite, that actually the people who were controls, not on glucocorticoids, there was a much higher proportion who had detectable FDG uptake by BAT, even at room temperature, as all these scans are done at room temperature. And generally the data is showing about between 3 and 8% of people will have detectable FDG uptake at room temp. Whereas with glucocorticoid treated people, we find it much, much reduced. So in fact, we think acutely increases, but chronic suppresses. And that may well be a novel mechanism through which steroids actually cause obesity in individuals. We've also started trying to use PET to try and develop other novel techniques that we can measure brown fat activity. For example, PET, we can't directly measure tissue concentrations by using PET. So what we were really interested in is measuring direct substrate utilization and direct tissue levels. And we thought we could try and adapt a technique called microdialysis to measure brown fat activity. So for people not aware, microdialysis, you insert a microdialysis catheter into your tissue of interest, and it has a semi-permeable membrane at the tip. And what you do is you put a perfusate at very, very slow rates through, and that then allows to equilibrate with your analytes of interest in the tissue, and then you collect that in your dialysate. And we thought supraclavicular BAT is the most common depot that we see, so we decided to see if we could try this and compare it against white fat in humans. Brown fat is incredibly tiny depots, and you can't tell on CT or ultrasound, MRI, what is white and what is brown. So we did a 2-visit study. We described visit 1 as a BAT finding day. So they did lean guys, again, FDG PET during cold exposure to identify and quantify it. We came back the next day, we started our tracers as usual, but in collaboration with Graham Weir, a radiologist at the Royal, he then did CT-guided insertion of a microdialysis catheter using the PET-CT data. And you can see here into the posterior brown fat, you can see the gold-tipped microdialysis catheter, while we also injected 133 xenon so we could measure adipose tissue blood flow continuously throughout mechanism. We then inserted an A line, an arterial line, so we could measure arterial interstitial differences and quantify substrate use by brown fat. And then we put them in a warm room for 3 hours in a cold room to activate their BAT. So we needed the PET in order to actually prove we were in the correct place here. I won't go through this data in too much detail, but what we've discovered is actually that brown fat is very metabolically active even at thermoneutrality, at warm room. That actually has enhanced cold glucose uptake by brown fat compared with white, increased anaerobic glycolysis, lactate production, and during cold exposure we see a reduction of glucose, we see a reduction of pyruvate and glutamate in brown fat, which we don't see in white fat. So we're actually finding for the first time that brown fat uses substrates other than just glucose and fatty acids during cold-induced thermogenesis. And we see that the reduction of tissue glucose levels correlates very nicely with cold-induced thermogenesis energy expenditure. One thing we've also wanted to do is what's the mechanisms going on? So we've used our PET-CT scans to try and localize brown fat for tissue collection. So if you take superficial fat from an area where you don't see FDG uptake, you get this nice unilocular lipid, white adipocyte, whereas if you take it from the deeper supraclavicular tissue, you see multilocular cells with big lipids, which positively stain for UCP1, which is brown here. So these are your hallmark of your brown adipocytes. And what we can do is we can culture the stromovascular fraction, differentiate them, and then actually use these human primary brown adipocytes for test regulation. So for example, carrying on the steroid theme, we found in humans here that actually giving low dose glucocorticoid enhances oxygen consumption by brown adipocytes, whereas in rodents we actually find that glucocorticoids suppress that. And we found that that mechanism is mediated by UCP1, the key protein I mentioned earlier, that in humans it enhances regulation and in rodents it suppresses it, which really highlights the importance of studying this in humans to find out whether novel drugs will be able to activate human brown fat. So what are we doing at the moment? I mean, we're about to start a new study with the new PET MR scanner, which I think is very exciting, in order to try and look at substrate utilization across different tissues during cold-induced thermogenesis, so skeletal muscle, white fat, brown fat, through it all. We've been sequencing our primary brown adipocytes and finding new genes that are highly expressed. And we've found that those are important in human brown fat activation. So we now want to go back from the bench in vivo, into humans and actually start using agonist inhibitors of these specific receptors in order to see if we can regulate human brown fat activity and develop novel PET tracers that might actually give us a lot more insight into human bat physiology. And the goal aim will be, I think, to use PET once we've found some pharmacotherapy where we might be able to assess the efficacy of actually activating brown fat as a novel tool to treat metabolic disease. So I'd like to thank everyone who's involved in all the studies, particularly everyone who funds my studies, and particularly all my volunteers, without whom I wouldn't be talking to you today. So thanks very much for your attention. If you have any questions, I can answer.
Probably got time for a quick question. To the back, Hillary.
Hilary Critchley. Roland, thank you very much. Really interesting. Have you had the opportunity in your studies in humans to look if there are any gender differences?
There, in terms of, in the initial data that came just from kind of retrospective analyses of PET CTs, women have a much higher proportion of active brown fat at room temperature, whether that's because they have slightly less skeletal muscle mass and therefore not generating as much heat. But when you do dedicated studies with cooling them down individually, we tend to see the similar prevalence. There is some evidence that estrogen actually enhances brown fat activity and that testosterone suppresses it, but we haven't seen obvious gender-specific differences. Most of the PET studies done, though, are in men because they don't tend to like doing as many in the women.
One more question.
Congratulations on the work. This is extensive work that you've done here, and I think you really have to acknowledge the help of your volunteers.
Yeah,
well done. So I wanted to ask you two questions. The aspect of modulation of the signal. Have you done any pharmacological maybe changes, or maybe in the animal or in the human, to see if the signal can be modulated by, let's say, a certain type of drugs?
I mean, people have. Obviously, initially, even before when we thought we discovered it, of course, radiologists knew all about it, long in advance, and they were using beta blockers potentially to actually suppress, confounding uptake. So people have used that. I mean, Aaron Cypes in Harvard has very much led the pharmacological development. He's using mirabegron, which is like a beta-3 agonist licensed for bladder condition, and he's found that he can enhance brown adipose tissue activity quite a lot and increase the FDG uptake using high-dose mirabegron, I think like 200 milligrams. Of course, it does tend to spill over into tachycardia and all this kind of thing. So it's difficult with all these, these sympathetic agonists in actually trying to activate it. But yeah, they can certainly, modulate uptake.
So it's very interesting that you mentioned beta-3. Beta-3 have had gained interest in the field of atherosclerosis as a potential drug to modulate the immune system. So that's my follow-up question. Okay. Have you been able to measure maybe vascular inflammation, since you're doing FDG, you're in the vasculature, to try to correlate the signal in the fat to the one that is in the vasculature? That will be a pretty neat experiment.
Yeah, no, we've never done that. I mean, inflammation has been shown to be very important in rodent brown adipose tissue. IL-4/13 seems to be key to activation. There hasn't been any evidence in humans of that yet. But yeah, that would be very, very interesting.
Thank you very much. So we'll move on. Thanks again, Roland. very much looking forward to doing the next PETMR study. Maybe get some spectroscopy into the mix as well. So our final speaker this morning in metabolic imaging is Dr. Jonathan Fallowfield. Jonathan and I have been collaborating quite a bit now using MR. Jonathan's based in the Centre of Inflammation Research. He's a senior clinical fellow there and is an honorary consultant hepatologist. He's got an interest in everything from basic science through to clinical application studies, and particularly in tissue characterization of the liver, and as mentioned previously, things like fibrosis, portal hypertension, and hepatic fat fraction. Jonathan.
Thanks very much, Scott, for the introduction. Thanks to the organisers for the chance to say a few words. So I'm going to talk a little bit, this is a whistle-stop tour through some of the exploratory studies we've done looking at biomarkers in liver disease. And I am a liver doctor, I'm not an MR physicist, so please be gentle with me. Why do we need biomarkers, and particularly imaging biomarkers in chronic liver disease? Well, we need them for diagnosis and staging of disease. We need them to monitor disease progression and also regression. And it's fair to say that clinical trials in chronic liver disease have been significantly hampered by the lack of robust, non-invasive biomarkers and have been really much sort of anchored to the liver biopsy. And we need biomarkers to enrich and stratify our clinical trial populations and to evaluate the efficacy of emerging therapies. We also need biomarkers that have prognostic value, and these should correlate with clinical outcomes or hard endpoints, like portal hypertension, for instance. And it's critical because trials in patients who don't have cirrhosis, so just have fibrosis or earlier liver disease, will not develop clinical events, clinical outcomes, so we will need surrogate endpoints in these people. So it's fair to say that I believe very strongly that we need an armamentarium of imaging modalities to enable evaluation of the next sort of generation of drugs that are going to be really important in liver disease to break down scar tissue, to improve portal hypertension, to protect the kidney and to modulate blood flow in the liver. And we've worked really hard together with Scott and other people in CRIC to look at a number of MR-based modalities that answer some of these different questions. And some, like arterial spin labeling of the kidney, for instance, is something very, very sort of hot off the press that we've just literally started doing. So everyone that talks about liver disease shows graphs showing an explosion in liver deaths and the prevalence of liver disease. And I'm not going to show that graph, but I will just labour the point that most of this is being driven by an increase in metabolic, obesity-driven liver disease, so-called non-alcoholic fatty liver disease, which is a worldwide problem, affects people in rich countries and poor countries. The epidemiological statistics and economic figures are absolutely mind-blowing now and will only get worse. And people with fatty liver disease have higher overall and liver-related mortality, so it's not a trivial problem. And it's NASH, which is the presence of fat and inflammation in the liver, which is the critical thing, because this is the harbinger of progressive fibrosis and liver cancer. And NASH probably affects around 5% of people in the UK, so we're talking about very, very big numbers. Because of this, pharma are extremely interested in NASH. There's no drug license for this indication, there's everything to play for, and there's a massive potential market for this condition. So we need, particularly in this condition, non-invasive tests that can stratify disease, you know, which are the guys with steatosis or with NASH, and which are the people that are progressing along this spectrum towards cirrhosis, so how can we monitor that? And I said we're anchored to the liver biopsy in hepatology, and that's still the case. I won't call it a gold standard, it's our best standard for the assessment of liver fibrosis. There's a sampling error, which is its main drawback. It only looks at 1/50,000th of the liver, and you can see here, if you took a biopsy from here, there's 5% fibrosis area. If you took your biopsy here, there's 70% area. So this is a significant issue. Added to that, there's problems with intra and inter-observer variation, and it's invasive. You know, people who are asymptomatic do not like clinical trials that involve needles being stuck into them particularly. However, it is still the FDA endpoint for anti-fibrotic trials, so there's a high commercial pressure for us to do biopsies. However, we should be asking, is fibrosis the best thing to measure anyway? It may not change quickly, predictably, or in fact linearly. And whoever you speak to, there'll be proponents of liver biopsy, there'll be people that love biomarkers, and there'll be people like me who, I'm a bio-cocktailist, so I try and use biomarkers and then I biopsy if I don't understand the biomarkers. And I kind of oscillate and mix with people that like biopsies and biomarkers. You've probably heard about elastography, which is a way of measuring fibrosis, and it measures liver stiffness as a surrogate. I'm not going to go into detail about this today, but I do want to flag it up as something that we use. Certainly transient or ultrasound elastography, this is something we use as a point of care test in the liver clinic. It samples 100 times more volume of the liver than a biopsy, so that's a good thing. The bad thing is that it is dependent on the operator and also on patient factors, particularly obesity. So there's about an 18% technical failure rate. MR elastography is great because you sample a whole slice of the liver, but it's a highly specialized technique, and we don't yet know whether it's sensitive enough to detect small changes either forwards or backwards in terms of disease progression. So we've been interested in multi-parametric MRI, and all the studies I'm mentioning now use 3 Tesla MRI, and we've been working with colleagues in Oxford who formed a spin-out company from the University of Oxford called Perspectum Diagnostics, and they have a proprietary algorithm which they call liver multiscan, which is now CE marked and FDA approved at 510K, and this is a multi-parameter technique which looks at fibroinflammatory injury in the liver, and here we use T1 mapping, so we measure the amount of extracellular water in the liver. The C bit means there's a correction factor, because we know that about 40% of people with chronic liver disease have elevated iron in the liver, and iron can confound and compete with the T1 level, so there's this proprietary algorithm to correct T1. Then we use T2 star mapping to look at the iron in the liver, and we use we've been talking about it already today, proton density fat fraction by Dixon method to measure fat. And also, of course, we can look at liver macroarchitecture, and what we've learned is that a lot of liver diseases are very patchy, and again, another reason why liver biopsy is perhaps not the best technique. So you'll get things like fat and fibrosis, particularly in cholestatic liver diseases, is very, very geographical within the liver. This is non-contrast. You can use it in obese patients. There's no additional hardware. It's a standard MR scanner, and it's quick. So there was a study, initial study in about 70-odd patients in Oxford, where they showed that this CT1, this fibrosis inflammation score, correlated with increasing fibrosis. It had a good area under the receiving operating curve to detect any disease, and they came up with this LIFT scale, which is represents a scale of focus for CT1 values in the liver, so it gives it a nice colorized scale. What I would point out, though, is in this small study, which had a lot of bariatric patients in it, this is the Achilles heel of all non-invasive biomarkers. It's teasing out these intermediate stages of liver disease, and in this smallish cohort here, again, it wasn't able to do that. One thing to quickly say is this technique can detect change. So this is the most overt example I could come up with. This is a patient who's had bariatric surgery, massive reduction in liver fat, massive reduction in the CT1 fibrosis inflammation score. So it can detect change. And perhaps more excitingly, there's some early evidence showing that it can also predict outcomes. So this LIFT score, this derived score, if it's over 2, you're much more likely to develop a clinical outcome. So not only is this good at excluding excluding patients that are low risk, it's also good at potentially enriching clinical trial populations for people that are more likely to develop clinical outcomes. So we did a much larger 2-center study with our colleagues in Birmingham to validate this technology in an unselected secondary care population. Anyone who was having an NHS liver biopsy for suspected chronic liver disease had contemporaneous biopsy, MRI scan, FibroScan, and this blood test, the ELF test. And we correlated the MR parameters with standard histological measurements and did the typical sort of diagnostic performance statistics you'd expect. We also looked at the reproducibility and repeatability of this technique, which of course is going to be important. And just to sort of gloss over some of this, it was very reproducible. We did in and out of the scanner testing, and we also got people back after 10 weeks and repeated it, and had very good reproducibility. Had a good success rate. The failure rate was 4% compared to 15% for transient elastography or FibroScan in this study. We showed that indeed the CT1 is a marker of fibrosis and inflammation. So as fibrosis goes up, the CT1 score goes up, but there's a significant interaction effect with inflammation. So we're learning more about this technique. It definitely measures fibrosis and inflammation. Here's fat in the liver, and there was very good a positive association with the amount of fat in the liver and the proton density fat fraction, and again a relationship between the T2 star and iron staining within the liver, and this is what iron looks like in the liver. So there's this, what we use clinically and certainly in trials is something called the NAS score, the NAFLD activity score, which is a composite score of steatosis, lobular inflammation and ballooning of hepatocytes, so liver cells that are sick. And the CT1 measure here had a positive relationship with increasing NAS score. And then if you look at people who had simple steatosis versus NASH, remember I said NASH is that sort of pivot point, inflection point in the natural history where people are at risk of significant liver disease. And again, you could begin to classify these patients into either group. And then we showed using this technique that we could actually tease out people who had pretty mild disease versus, pretty mild disease or basically non-significant low-risk disease. So we're beginning to make inroads into the early stages of liver disease where many techniques like FibroScan are not sensitive enough to interrogate. So just to kind of wrap up some of that work, we think we can detect early liver disease, and we may be able to classify patients who have NASH versus steatosis. It seems to be quite good at excluding clinically significant liver disease, and the negative predictive value is better than for FibroScan, for transient elastography, and for the ELF test. In this particular cohort, it didn't appear to be any better than the others for detecting fibrosis. But interestingly, we did some health economics, and it did appear to be cost effective if you put it into the NHS sort of diagnostic workflow. And I think that's going to be important when you're looking at novel technology in clinical practice. So Scott mentioned earlier on about portal hypertension, and we desperately need non-invasive biomarkers for portal hypertension. The reason is that the portal hypertension, which we measure by hepatic venous pressure gradient, which is an invasive technique, you stick a catheter through the jugular vein and inflate a balloon in the hepatic vein to measure pressure, and these are the sort of tracings you get. If your portal pressure is low compared to high, you're much less likely to develop clinical complications and die of liver disease. So this is a hard endpoint. The FDA really like portal hypertension. But we need a non-invasive correlate. You can't go around sticking catheters into people's necks and blowing up balloons. They're just not going to go for that. So we need non-invasive approaches. And there are various things that have been tried so far. The first thing to say about portal hypertension is it is very, very complicated, and a single blood test and a single imaging test is unlikely to crack it. And these are just some of the things that happen in the substance of the liver and in the wider circulation. So there's loads of stuff going on. So I think we need a multi-parameter approach to measure portal hypertension. And one way we've started to look at this was in a study we did using a vasoactive hormone called serelaxin, which we hoped would have beneficial hemodynamic effects on the kidneys and the liver in patients with cirrhosis. So here's relaxin here, and this is some phase contrast MR angiography that we did to look at blood flow in different parts of the circulation in these patients. It's a phase 2 study. The primary endpoint was an MRI measure of renal and also hepatic blood flow. We use terlipressin as a positive control. This is something that we use clinically. And just to sort of say, we did actually in a small group of patients also directly measure the pressure in the hepatic portal vein. So again, just to cut this bit very, very short, using MRI, we showed a significant and very exciting increase in renal blood flow in response to serelaxin. And this is a potential game changer in my particular area of expertise in hepatology. So we're hoping that this will lead to further phase 2 studies where we can start to link hemodynamic beneficial changes to functional changes. And then following on from this, we for the first time began to see whether we could use these sorts of measurements to look at clinical response to beta blockers. And we use non-selective beta blockers in patients with portal hypertension to reduce the pressure and reduce the risk of bleeding. And no one has ever done this before. Again, we tend to either do nothing or feel the pulse and measure the blood pressure and hope that these drugs are working. But we use these techniques to look at the liver composition and the spleen composition, and also blood flow in different circulatory beds. And just to cut a long story short, we showed that the aortic blood flow, so that's a surrogate of cardiac output, that went down significantly. This was a small pilot study, and although we saw some trends to change in other vessels, we didn't see any statistically significant changes. But I think we did show very good agreement in assessment between different assessors. And again, we did look at the texture in the spleen and in the liver. We used the CT1 again, and very variable in this small study. But other people have looked at the spleen specifically and shown it correlates with portal hypertension. I think there's some more mileage to come here. So just to wrap up everything and sort of finish, we still haven't got a perfect, fully validated test for quantifying fibrosis. But I think imaging probably holds the key. And imaging plus a blood test is likely to be the way forward. I've only talked about a few things. There are lots of other MR techniques using, Peter Caravan in Harvard has got some really nice work using collagen and elastin MR probes. There's a potential for PET tracers as well. And I think multi-parameter MRI looks really useful for assessing fatty liver disease, particularly some of the drugs that we're likely to be using in trials have differential effects on fat, inflammation and fibrosis. So it may enable us to unpick effects of drugs. And then portal hypertension, I think, is a really important area, but will likely need a multi-parametric approach. And just to finish off, we've just got a big grant from Innovate UK, and this isn't a paper that I read at all, but again, it's just brilliant tabloid journalism, and Scott, you'll love this, because it says, MRI scan could save lives. So I think it's really exciting. Everyone thinks that MRI is great, and we're going to use it in surgical patients to see if we can get a better handle on pre-existing liver disease, which is often silent and an important factor in determining outcome after liver resection surgery. We're also using the same technology to look at the effect of chemotherapy that people have before liver surgery. We know that chemotherapy-induced liver injury is a significant problem, and we can also look at the penumbral effect of transarterial chemoembolization in the liver in patients with hepatocellular carcinoma. So some really exciting work which we can do in patients who are going to have liver surgery. So I'm just going to thank research fellows that did a lot of the hard work in some of these imaging studies. Scott, who's really my kind of point man in Crick, who's been really good to work with. Dilip, who is our NHS reporting radiologist. Peter Hayes is another enthusiast in hepatology. David and Gillian also who've been very helpful with some of these studies. And then all the research nurses in the CRF and people in the Crick who've helped with these studies. So it's a really exciting time in liver disease for imaging, and thanks for listening to me.
Thanks, Jonathan. It's nice that we're saving lives.
You are saving lots of lives.
I'd be very excited to try and add renal perfusion studies with ASL to this patient, especially if we get another crack at Cerelax in patients. That'd be really good. Any quick questions before we go for coffee?
Thank you. Thank you for that. That was really interesting. I was just interested, you started off your talk mentioning the limitations of liver biopsy for misclassification of patients, and then you went on to talk about, if I understood it correctly, a diagnostic accuracy study of this multi-parametric MR using the same flawed reference standard. How do you know you have classified your patients correctly, and therefore how do you know, or how accurate do you think your results actually are?
That's a great question. I mean, that's the problem with an imperfect standard. I mean, the one thing I would say is that we can do better with biopsy. So some of the graphs I didn't show, what we actually do now when we're assessing fibrosis in the liver is we stain the liver and we do digital image analysis to quantify the collagen, and so that's a continuous variable. It's a quantitative data as opposed to these semi-quantitative scoring systems that we've used historically to stage fibrosis, which are ordinal data and is much harder to compare. So it's fair to say that we can use the biopsy better. Also, biopsy length is critically important. I didn't have time to go into the methodology. We were very, very stringent on the length and quality of biopsy, so we used the best evidence we've got to make sure that the biopsy quality, and anyone that didn't have a biopsy that was up to scratch got taken out. So I think, biopsy is what it is, and we need to try and move away from it. It's always difficult comparing something with an imperfect gold standard. That's for sure. But I think you can use better analysis techniques to drill down onto the biopsy.
Okay, so in the interest of time and probably to get everyone up for a cup of coffee and a bit of a comfort break, we'll break there. I'd like to thank all the speakers again for a really great series of talks, and be back here for the next session at 11:15. So thanks again. Coffee's upstairs.